Good morning, everyone. I'm back for part two. This time we're going to talk about some of the basic physiologic principles of acid-base, again, to provide you with a framework for approaching clinical problems. So pretty simple outline. Again, much of this is by way of review from your medical school and training days, but it's still very useful to review these basic approaches. And of course, we're going to talk about acidosis, respiratory metabolic, alkalosis, respiratory metabolic, with an emphasis on the metabolic processes, but we will touch briefly on the respiratory ones as well. So, when approaching an acid-base disturbance, there are three important questions. You want to look at the pH and determine whether there is acidemia or alkalemia. Those are the correct terms for the hydrogen ion concentration in the blood. You then want to try to determine which is the primary process and whether it's an acidosis or alkalosis, and is it metabolic or respiratory? And you can tell that again by looking in which direction the pH has gone. And then very important to determine whether there's appropriate compensation. And I'll show you some of those rules of thumb and review with you the direction of compensation. So very simple definitions: acidemia less than 7.35 for the pH, alkalemia greater than 7.45. This is the Henderson-Hasselbalch equation, maybe a little deja vu for some folks. And this is the main buffering system in the body, the bicarbonate buffering system. And it's defined as 6.1 plus the log of this ratio, the bicarbonate, which is the metabolic process, over the acid, which is the respiratory process. And this is the actual equation for the conversion of CO2 and water going to hydrogen ion and bicarbonate. So this is 99% of what we talk about in acid-base and interpreting pH. So for an acidemic situation, it's a pH of less than 7.35. If it's a metabolic process, the bicarbonate is going to be low. If it's a primary respiratory process, the pCO2 is going to be elevated. Again, anything that lowers this or raises this will lead to a reduced pH. And the opposite is true for the alkalotic processes. So then, is there an appropriate compensatory response? So if you determine that the primary process is a metabolic one, defined as a decrease in the bicarbonate, we are going to expect respiratory compensation in the opposite direction, meaning that it's going to elicit a respiratory alkalosis. So by driving the pCO2 down, you offset that ratio and restore the pH towards normal. However, an important rule of thumb is that our compensatory processes do not return us back to a normal pH. So a little pearl is that if you see a clear acid-base disturbance in a normal pH, you're almost certainly dealing with two primary processes. And likewise, you can determine or you can estimate whether the degree of the respiratory alkalosis is appropriate. This is the Winters formula. There are others. I just find this one easier to remember: 1.5 times the bicarb plus 8 plus or minus 2. And these will be used in the question and answers that are in your afternoon session. If the primary process is a respiratory alkalosis, you're going to expect, again, the opposite process being metabolic and in the opposite direction. So a respiratory alkalosis will lead to a metabolic acidosis as compensation. Here are the rules of thumb. Again, these can be looked up when interpreting a gas. Those of us that do a lot of this will remember them, but I don't think you're expected to remember them for the purposes of the board's. And again, if the primary process is a metabolic alkalosis, you'd expect a respiratory acidosis. Here's the rule of thumb for that compensation. And again, the opposite primary process leading to the appropriate compensation. And there's the rule of thumb for that correction. Okay, so remember that the direction of compensation, that it's almost never complete. So let's briefly talk about respiratory acidosis. So these are going to be processes that result in hypoventilation or an elevation in the PCO2. So that will then lead to this decrease in pH. As the PCO2 rises, the pH is going to drop. And this is a very simple outline of a huge differential diagnosis for processes that would lead to a respiratory acidosis. And it can range from central processes affecting the nervous system to the respiratory muscles and the chest wall pleura colored in green, or then to the direct pulmonary tissue itself, either in the airway or the lungs. So won't breathe, can't breathe because of muscle problems, or a primary pulmonary process where you can't breathe enough. So that's all I'm going to say about respiratory acidosis, as it has, again, that broad differential that covers a huge amount of internal medicine. What about metabolic acidosis? This is also very commonly seen. And what is it? Well, it's really the retention of hydrogen ions. So that's how we develop a metabolic acidosis. And there's a variety of ways that this can occur. One would be that we ingested acid, and that can certainly be seen in certain intoxications. There could be generation of endogenous acid. So processes that lead to lactic acid or other acid production will lead to an accumulation of hydrogen ions. We could have a problem with acid excretion. That would be a renotubular acidosis, a renal problem. Or we can lose bicarbonate, because the loss of a bicarbonate is, by definition, the retention of a hydrogen ion concentration. So we can now dive into these in a little bit more detail. And ingesting acids is something that needs to be on the radar screen for any patient presenting to the emergency room with an altered sensorium and an acidosis. The common ones are ethylene glycol, methanol, toluene, aspirin or salicylic acid. And here are the acids that are generated from alcohol dehydrogenase. So ethylene glycol will convert it to oxalic acid and glycolic acid. Methanol gets converted to formic acid, toluene to hippuric acid, and salicylic acid is already an acid. What about generating endogenous acids? Well, commonly, and we often encounter in our clinical practice, lactic acidosis from a host of potential etiologies. Ketoacidosis, typically associated with diabetes or alcohol, and rhabdo, which is most commonly associated with some lactic acidosis. So defective acid excretion. If we have impaired renal function, again, the kidneys are the main way that acid is excreted through the generation of ammonium chloride. And if we have reduced renal mass, we have defective acid secretion. And the common metabolic acidosis that we see in our patients with chronic kidney disease. And then the more selected disorders where hydrogen ion secretion is affected in the distal renal tubular acidoses. And finally, how do we lose bicarbonate? Well, again, there's only a couple of ways out of the body, through the GI tract in the form of diarrhea, which is a very common cause, or in a less common cause, a proximal renal tubular acidosis. But I find this a useful framework to think about the different mechanisms of acid generation. And then, of course, when confronting an acidosis, one wants to calculate the anion gap, which is the sodium minus the chloride plus the bicarb, or the unmeasured anions minus the unmeasured cations. So these are going to be acids that are non-chloride, because the chloride would be counted up here in the buffering of the bicarbonate. So I find this picture a useful schematic to conceptualize this. We have the negative charges here on the left and simplistically the positives on the right, mostly sodium, as we talked about earlier. And it's the chloride and the bicarbonate are our major anions offsetting these cations. And then we have our gap. And the gap is made up of phosphates and sulfates, but the largest contributor is albumin. And of course, you do want to correct for a low albumin when calculating an anion gap. So here we have addition of an acid. So it's a hydrogen ion, but it's not chloride. So what's going to happen to that anion? It's going to get buffered by bicarbonate, but because it's a non-chloride containing acid, our gap is going to expand. So this is by definition the anion gap acidosis, or the addition of an acid with an anion other than chloride. This is in contrast to a non-anion gap acidosis, and we'll come back to this in a few slides, where the gap remains the same. The bicarbonate compartment has shrunk, therefore we have our acidosis. And this can happen two ways. We can drain bicarb out of the system, as in diarrhea or an RTA, or we can retain an acid such as HCl or ammonium chloride, as you might see in renal failure, and end up with an acidosis that's non-gap in origin. So this is an old now but useful mnemonic for remembering the differential. I grew up with Kussmaul, others may have others. This is Goldmark, glycols, oxyproline, L&D lactate, methanol, aspirin, renal failure, and the variety of ketotic conditions. So the other place that the gap is very helpful is in helping distinguish amongst different intoxications. Again, these are going to be patients presenting with an acid-base disturbance, often with an altered mental status, to the emergency room. And here I've divided them up into those with an anion gap and not, as well as an osmolar gap, which I'll show you on a subsequent slide. But the osmolar gap is also very important to calculate when considering ingestions. Because salicylate's a small molecule, it doesn't contribute to an osmolar gap, but will give you an anion gap. Here are the classic intoxications of ethylene glycol, methanol, propylene glycol, and even ethanol can contribute to both the anion gap and osmolar gap. And then an interesting one that I've seen a few times is no anion gap acidosis, but a high osmolar gap, often seen in patients who've ingested isopropanol. And these patients will smell like acetone because that's what isopropanol is converted to. It's not an acid, but the acetone contributes to the osmolar gap, but doesn't create an anion gap acidosis. So this is the way to calculate the your serum osmolality. And then, of course, you want to compare this to what's measured in the laboratory. For those of you in Europe who work in millimoles, you don't need to use these correction factors of the molecular weight. We measure sodium in the United States in milliequivalents, so you can just double that. This is taking glucose and dividing it by its molecular weight divided by 10 to get the units into millimoles, and the same for urea nitrogen. So if you're confronted with a patient that has a variety of these symptoms, let's go through some of their common clinical presentations. So if you have a patient with a high anion gap acidosis, smells like alcohol, has papilledema, also an osmolar gap, but no measured ethanol, one should think about methanol intoxication. The eye is unfortunately a common and severe target for the formaldehyde that's generated from a methanol conversion by alcohol dehydrogenase. And this is where you might find it. A different patient with no odor, but an osmolar gap and calcium oxalate crystals seen in the urine or perhaps in the eye. And these are the crystals that you would see in the urine of calcium oxalate. And that's what you might see in a patient with ethylene glycol intoxication. Ringing in the ears or deafness is always a clue to think about aspirin. The other clue to aspirin is that it's a primary central nervous system stimulant for respiratory drive. So these patients are often hyperventilating or will be hyperventilating, at least prior to their, decompensating into respiratory failure. So you'll see an associated respiratory alkalosis primary and a primary metabolic acidosis. And that's aspirin. If you have a normal glucose, but a serum acetate or acetoacetate that's negative or borderline, but a positive serum beta hydroxybutyrate with or without ethanol, you might think of alcohol ketoacidosis. Certain drugs, such as didanosine or stavudine, often can be seen within a few months to a few years with an elevated lactic acid, and this would be a drug-induced or a type B lactic acidosis due to mitochondrial poisoning, as opposed to the classic hypoxia-induced lactic acidosis. One last one, short bowel syndrome by history. Episodes of altered mental status associated with an anion gap metabolic acidosis, typically after a high carbohydrate meal. It'll go away if they're kept NPO, and the serum lactate is negative, but you have to think about and then specifically test for a D-lactic acidosis, but you have to ask this specifically from the lab. The altered mental status in a patient with short bowel, this should be considered in your differential. One more, an ICU patient who's been sedated with high doses of lorazepam, has an osmolar gap and an elevated serum lactic acid level. This is the propylene glycol intoxication that we don't see very much anymore, probably just through better ICU medicine and monitoring. So I showed you this cartoon before, but now I want to emphasize the differential diagnosis of a non-GAP metabolic acidosis. So by way of review, we have our cartoon with the negatives and the positives on each side and our GAP. And to remind you that we can end up with a low bicarb, i.e. a definition of an acidosis, without an anion gap by two mechanisms. We can add an acid that contains chloride, so HCl, or we can drain bicarb out of the system either through a renal or GI mechanism. So this is the way I like to think about it, because there's really only two ways or two routes to lose bicarb. There's a GI route and a renal route. This is very common and often doesn't reach the attention of a nephrologist. This is much less common, but this is the renal equivalent of bicarbonate wasting due to a proximal RTA, and can be seen with certain drugs as well as paraneoplastic conditions such as multiple myeloma and other autoimmune disorders. And then if we're not losing bicarb, but we're retaining HCl, how does that happen? Well, it happens through renal tubular acidosis, and these are roughly divided into the distal or the classic distal, or the type 4 hyporeninemic hypoaldo that I had mentioned briefly during the first talk. So these are the main RTAs that you'll encounter, very different mechanisms that lead to the condition, but the end result is a non-anion gap metabolic acidosis. So this is a little table summarizing how to distinguish these conditions. The proximal, the type 2, the distal, type 1, and the type 4 hyporenin hypoaldo. This one's pretty easy because it's the only one that's associated with an elevated serum potassium. These others are typically associated with a low serum potassium. So that's a very useful distinguishing factor. The urine pH depends. This will depend upon how much bicarbonate is being spilled into the urine as to whether it gets above 5.5 or not. The classic distal is almost always inappropriately elevated, whereas with the hyporenin hypoaldo, it's typically an appropriately low urine pH. These are some of the causes, the proximal RTA from Fanconi syndrome, characterized also by loss of phosphate in the urine. A clue that I'll give you a hint for one of the questions in the subsequent session is that if you see glucose in the urine in the setting of a normal serum glucose, that should really raise your suspicion for a proximal RTA. The one exception now, of course, is with the wider spread use of SGLT2 inhibitors, which promote glycosuria, and you may have a normal serum glucose, but that would be obvious from the history. And then calcium-based stones as a hallmark of the classic distal RTA. This is just an expanded differential of different drugs and the treatment, including Sjogren's and lupus and older drugs such as amphotericin. We talked a bit about the hyporenin hypoaldo. And down here are the treatments for these, none of which are perfect, but can help offset some of the acidosis that patients have. Quick word about respiratory alkalosis. So this is going to be hyperventilation and decreasing the PCO2. Decreasing the denominator is going to raise the pH. And again, a long internal medicine differential that I'll just highlight the broad categories of any pulmonary disorder, from pulmonary embolism to pneumonia, et cetera, cardiovascular disorders, metabolic disorders, endocrine disorders such as hyperthyroidism, neurologic disorders that stimulate hyperventilation, ranging from panic to more severe things like brain tumors, any form of sepsis will give you a primary respiratory alkalosis, liver failure, and pregnancy. And again, we're just going to leave it at this high-level list of broad possibilities for hyperventilation. All right, well, what about metabolic alkalosis? So again, if an acidosis is retention of a hydrogen ion, this is going to be retention of bicarbonate. And how can that happen? Well, again, we can ingest alkali. These are milk alkali syndrome and usually inadvertent, but you can ingest alkali. Another way you'll generate a metabolic alkalosis is to lose acid, either through the GI or renal mechanisms, or again, a cellular shift. So milk alkali syndrome or overdosing on antacids can do this. A lot of blood transfusions due to the citrate that's used to preserve the blood will also contribute to the development of a metabolic alkalosis. So it's not really an ingestion, but it's an administration through the blood. You can have GI and renal losses of acid. Most commonly would be vomiting and NG suction. These are similar because it's loss of hydrogen chloride. Or you can have renal losses of acid through the use of diuretics, the hereditary disorders that are at the same site that our common diuretics are used, Barter's and Gittleman's, or hyperaldosteronism. And opposite of what we talked about in the potassium talk would be a low serum potassium promoting shift to develop a metabolic alkalosis. So metabolic alkalosis is not something that develops on its own. It needs to be maintained. And the hallmark of maintaining it is ongoing volume contraction. Hypokalemia and renal failure may also be major contributors, as well as hyperaldosteronism. And it's the excreted bicarb that is not being reabsorbed that obligates the loss of the positive charges in the urine, the sodium and potassium. And we had talked briefly about this in the earlier talk. The volume depletion stimulates aldosterone, which then promotes avid sodium reabsorption until there's no chloride remaining. And it also stimulates the HK ATPase, which exacerbates both the hypokalemia and the metabolic alkalosis. So a useful rule of thumb to look at is the urine early, particularly in vomiting or NG suction. You may not see a low urine sodium. It may be high due to the obligate bicarbonate in the urine, and therefore you'll actually have an alkaline pH. But the urine chloride should be low, and that will be helpful to distinguishing this from a renal source, such as someone who was abusing diuretics. Whereas after this has been going on for a while, everything is maximally reabsorbed, and the urine will reflect that. This cartoon just shows that you have to give chloride. You have to give sodium chloride to patients with a metabolic alkalosis because it's the absorption of chloride here in the collecting duct through these intercalated type B cells that will promote and allow for the bicarbonate excretion. So if you're confronted with a patient with unexplained hypokalemic metabolic alkalosis, I had showed you this slide earlier. Again, the only one that's associated with an elevated blood pressure would be hyperaldosteronism, whereas surreptitious vomiting, diuretic abuse, or the hereditary disorders will either be normal blood pressure or mildly volume depleted. Diuretics and defects in the transporters will lead to high urine chloride, whereas if you're vomiting, and the history isn't clear, the low urine chloride is your clue to that unexplained hypokalemic metabolic alkalosis. These two are difficult to distinguish in the absence of a diuretic screen, although the family history, of course, and the social circumstances can often be very useful here for patients that might be predisposed to bulimia or diuretic abuse. So we're a few minutes ahead of schedule. I'll leave you with my take-home messages. Remember the three rules of thumb or the three questions you want to address when looking at a blood gas result, and there'll be examples of this in the case presentations. You want to assess the pH, whether it's alkalemia or acidemia. You want to look at the PCO2 to see if it's a respiratory process or the bicarb for the metabolic process. And it's the ratio of these that determines the pH. Remember that compensation is the opposite process and direction, but not to a normal pH. Respiratory acidosis is defined as hypoventilation for the alkalosis. When thinking about a metabolic acidosis, a high anion gap is the addition of a proton with a non-chloride anion. So ketones, toxic metabolites, lactate, whereas a normal anion gap can be achieved by retaining HCl through a renal mechanism or through a bicarb loss through a GI or renal mechanism. Metabolic alkalosis, the differential is shorter. It's loss of chloride, and the two ways that are most commonly seen are with vomiting and diuretics. So I'll stop there. Got a couple of minutes to spare and turn it over to Dr. Smith.
Thank you. Thanks, Brad. That was great. So there are a few questions in the chat, and I'll take them. So the first one is just related to your previous talk, particularly on hyponatremia. And the question is, if a patient with hyponatremia is overcorrected, what's the next best step to take?
So if you overcorrect and catch it, there's no harm if you bring them back down to your target goal. So let's say you were targeting 120 and you went to 125. You would actually do the calculation to calculate how much water to give back to bring them back down from 125 to 120. These days, most of us are using DDAVP, which will shut the urine free water excretion down. It will turn the patient more into a beaker where just what we're adding will affect the sodium concentration. So in someone that's urinating, the pearl there is that the patients that are going to overcorrect too rapidly are those that are urinating a lot. And they're urinating free water for one reason or another. You've corrected their hypovolemia, the thiazide's wearing off. And those are the patients to be on the lookout for overcorrecting. And you can either give back the free water, well, you will give back the free water, and you can try to reduce their ongoing losses through the use of DDAVP.
Great. Another question. In outpatients, we see increased anion gap sometimes in healthy patients. Lab reports reports it. Is there any clinical significance to an increase an anion gap in patients for whom you don't suspect any specific acid-base disorder?
So I've seen this too, rarely in my clinic, and have looked for causes and could not find one. I guess I would look at the serum albumin concentration, but if they're otherwise completely healthy and otherwise, I wouldn't pursue it.
And then last question, and I know there are many other questions, but we only have time for another one. Could you comment on the use of acetazolamide in metabolic alkalosis, especially in diuretic-induced metabolic alkalosis, like in treatment of heart failure?
Yeah, so acetazolamide is the carbonic anhydrase inhibitor, which prevents the recycling of bicarbonate in the proximal tubule and basically causes the type 1 RTA. I'd be careful using it in patients that have been aggressively diuresed, because you're going to be enhancing, further, perhaps their volume depletion, and this may make this may worsen that. It can be used in those with refractory alkalemia or alkalosis that have reasonable renal function to promote the bicarbonate wasting. I don't use it too often.
Okay, great. Thank you. That's fabulous. I appreciate it. And thanks again for joining us this morning.
Well, good luck to everyone, and welcome to the new formats. Thanks, Ajay.